And so finally, let's talk about prostate cancer. So tell us what happened here at ASCO 2025.
Yes, so we heard an update about the ARANOTE quality of life. And this, as a reminder, is the doublet ADT with darolutamide, our ARPI combo, which was also FDA approved this week, just at the end of ASCO. Previously, this has been FDA approved per NCCN as a triplet combination with docetaxel based on the AirSense study. And so the quality of life aspects, do benefit darolutamide. However, we don't capture things like sexual dysfunction and other things that might be interesting to know when we're counseling patients. And I think that, when thinking about which of the ARPIs or androgen receptor pathway inhibitors to start, it's really important to still think about comorbidities, to be counseling patients on the quality of life updates as well. And another really exciting update, maybe some of the biggest data presented at ASCO as far as GU, is the phase 3 Amplitude trial. And this looked at niraparib, 200 milligrams once a day, with abiraterone, 1,000 milligrams, in metastatic castrate-sensitive prostate cancer with specific homologous recombination repair, or HRR mutations. For fellows, remember that we only have PARP inhibitors approved in the metastatic castrate-resistant prostate cancer. And we know that the greatest benefit is for patients with BRCA2. But here there were more than just BRCA2 included. And also remember that in this trial, they did the 1,000 milligram dose of abiraterone. That has to be given on an empty stomach. But there also is the 250 milligram dose of abiraterone, which can be given with a low-fat breakfast. And so the Amplitude trial did meet radiographic PFS endpoint with a hazard ratio of 0.52 in the BRCA mutated group and then 0.63 in all HRR mutated. One of the caveats is that only 36% in the control group did get a PARP inhibitor at progression, and the overall survival data is still immature. So I think there's still remaining questions, including how to sequence this with our other frontline category 1 options, including triplet therapy with chemotherapy, how to sequence this with radioligands, and to be beware of long-term toxicity like AML or MDS. They can absolutely test you on this on boards. And then also financial toxicity. So a quarter of patients on this trial did have anemia requiring intervention. So I think we, as hematologists also need to be comfortable in managing anemia. And then the last study that I want to talk about is a shout out to my GU fellowship mentor, Dr. Ong, with an update from data from the Ironman registry. And so he talks about the importance of a PSA response for patients who start that doublet, the ADT ARPI, and metastatic castrate-sensitive prostate cancer. And this was a huge international registry. And we do know that patients that have a PSA of over 0.2 at 6 to 12 months have a worse prognosis. And this is the data that he presented. And those with a PSA under 0.2 have a good prognosis. And so there are trials looking at both escalation for patients that have a PSA over 0.2. There's a trial called Triple Switch now open. And then trials looking at de-escalation in this setting. There's the ADREAM and de-escalate studies. And I think this is really important when we're counseling patients to say, the level of PSA response really matters. So for those patients that have a PSA of under 0.2 that have been on ADT and an ARPI, we know that those patients are going to have a good prognosis. Could we be thinking about pulling off that ARPI? We don't have the answer to that yet. And then for those that have a PSA over 0.2, we know those patients have a worse overall survival. So can we think about adding chemo or adding other things so that we can have better responses long-term?
Right, that's awesome. And obviously, if we're de-escalating, we're also de-escalating side effects and long-term toxicities, which is so important in the prostate cancer population because we do give them metabolic syndromes.